Hi, everyone. My name is Stephen Chuan. I'm a PGY1 in internal medicine. I'm happy to present Thinking Beyond Stevens-Johnson syndrome and toxic epidural necrolysis, a case of rare cutaneous drug emergency. This is a clinical vignette on a case of drug-induced linear IgA bullous dermatosis, an immunobullous disease in which autoantibodies target structures essential for skin integrity and mucous membranes. A 60-year-old female with no past medical history presented with decreased LOC, hypertension, and tachycardia. Initial blood work demonstrated leukocytosis and elevated lactate, and urine collection was visibly contaminated and was positive for leukocyte. A presumed diagnosis of sepsis secondary to urinary source was made, and she was given ceftriaxone followed by vancomycin and piptazo. At the time of admission, there was no documented allergies, and patient was unwell to confirm. Later, upon clinical improvement, patient later clarified that she had a remote history of hives caused by ampicillin. But given the lack of any adverse effect, antibiotic course was continued and completed for 7 days. 4 days following completion of antibiotic therapy, she developed a diffuse erythematous eruption on her body with areas of desquamation with no mucosal or ocular involvement. Allergy service was consulted, and by that time, lesions covered 90% of her body surface area. Skin biopsies were taken. Patient became hemodynamically unstable, requiring transfer to ICU, where she was started on methylprednisolone and etanercept for presumed 10. Patient unfortunately passed away later on. The result of skin biopsy pathology was made available postmortem and demonstrated subepidural bullae with eosinophils and neutrophils, consistent with an immunobullous disorder. The favored diagnosis was linear IgA bullous dermatosis. There were no features to suggest a diagnosis of SJS or 10. Linear IgA bullous dermatosis is typically manifested by a rough onset of vesicle or bullae with clear fluid on trunk, face, limbs, or even in mucosa. It is caused by linear deposits of IgA in the basement membrane zone. Multiple factors are reported to cause this condition, including medications. Vancomycin, however, is the most commonly implicated medication. The diagnosis is made via skin biopsy and direct immunofluorescence. The mainstay treatment is with dapsone. There are key features that can be used to differentiate this condition with SJS and 10. Mucosal involvement is almost always seen in SJS and 10, but only up to 45% of drug-induced linear IgA dermatosis has mucosal involvement. In terms of the underlying pathology, linear IgA dermatosis is characterized by neutrophilic and eosinophilic dermal infiltrate, whereas SJS and 10 have the classic keratinocyte necrosis. Finally, direct immunofluorescence demonstrates IgA deposition along basement membrane in linear IgA bullous dermatosis, but this finding is not present in SJS or 10. In summary, blistering disorders have similar clinical presentations, which make it difficult to distinguish from SJS or 10. Key to correct diagnosis is the utilization of both histopathology and direct immunofluorescence when histopathology alone is not contributory.